¿Listo? A continuación vamos a tener la charla del doctor Vinay Nadkarni del Children's Hospital of Philadelphia con su charla Just in Time, Just in Place, Healthcare Provider Training.
Thank you. You're welcome. Well, thank you very much. It's really a great pleasure. I'd like to share with you now some thoughts on the next generation of training. Very important for the students and the residents, but also important for the providers, because what we're recognizing is that just getting trained, just taking a course, just getting a certification is good, but it's not enough, because the continuous process of learning and contextualizing, adapting the learning to the patient that you're caring for today, particularly when it's a complex patient, is particularly important. And so, although I have some funding and sit on some scientific advisory boards, I'm not intending to endorse any product that I might show you in any of the photos. We have talked a little bit over the past 2 days about how important teaching, learning, remembering, acting, and acting well is for the outcomes of our patients and providers and our own personal satisfaction that we're doing a good job, doing the best job that can be done. And so I'm going to start with the end in mind. In all of our training, the objective is to start with the end in mind and then to do the appropriate training that brings us to the point of care delivery. So I'll start and end with the same messages. What have we learned over the past 20 or 30 years, maybe even longer, Jaime, over what works and what doesn't? So we recognize that one size doesn't fit all, and generally physiologic considerations take precedent over anatomic types of considerations. And there's such a spectrum of disease that just putting a label like sepsis or Duchenne's muscular dystrophy or mitochondrial disease on a patient doesn't really characterize their individual response and their disease state. So one size does not fit all for patient care or for training. We know that there are certain things, and I'm going to use the example of CPR because it's close to my heart, where both skills and behaviors, teamwork, are important. But what we're recognizing is that the practice to achieve the behaviors, the communication, the teamwork, and the response is equally important to having the appropriate skills or knowing what to do. We can know what to do, we can have the skill to do it, but if we can't activate the team and the processes and the environment around us to deliver that, it still doesn't work for the patient who's looking up at us and needs that to be done. We are learning more and more that big doses of large amounts of training are very good to start us up for knowledge and skills, but that we have to reinforce this with low-dose, high-frequency training. Little bits of training that are embedded into the care of the patient, and we may not even realize that it's training. It may just be reviewing. We can call it many things, but it doesn't have to take long. It doesn't have to be complicated. It doesn't have to be expensive. And, in fact, it can improve our efficiency. Oftentimes, our administrators believe that education is in one bucket and patient care is in another bucket. But what we have to think about is how we're going to move those two buckets and mix them together so that education becomes part of training, becomes part of education, becomes part of patient care. So that they mix, and so we can start to derive training from what we do on the patients, recognize that, and account for it as training. And those things that we're not doing commonly, we can train for those rare events, and we can pull them in and incorporate them to the training, to the patient care when we need it, just before we deliver the care. This is called just-in-time training, just in time, just in place, because it's happening at or near the point of care, right before you have to do it. Because now we don't look at our textbooks, we ask Google, or we go on our algorithm or download the app right before we have to do something. And we're not going to read a whole book of directions on how to do something. We want to know what we need to do for the next step, and then click, 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 and when we get stuck, we're going to ask for help for that next step. And so the whole way that we do things has changed. And so indeed our training systems have to change as well. We have to inform our training better with the specifics of what happens in our environment. So what we're learning is that going to courses like ACLS, PALS, NRP are great for general training. But when I actually go to my delivery room, to my ward, to my ICU, I need to know how that training is going to be implemented in my environment of care and with my team in the morning, in the afternoon, at night, on call. All of these situations differ. So I need to be trained and capable of delivering that in that situation. We know that highly practiced teams work better together. We know this from sports. We know this from aviation. We know this from many industries and businesses. But in the ICU environment, in the hospital environment, in the clinic, we rarely practice to perfection. How much time do sports teams spend practicing? And how much time do they spend playing? 98% of the time of the professional sports teams is in practice. And then the actual game is only 2% of their time. How about for doctors and nurses and respiratory therapists? It's completely the opposite. 2% of our time is spent training, and 98% of our time is spent delivering care. We have to think about why they are Olympic athletes and how they train and how they perform and the time balance that we allocate to that. We have to learn from each other, and so we are getting better at collecting data as we're delivering care and training. So it can be banked, it can be analyzed, it can be big data, where we can start to derive those things and replay them and reenact them in order to train better. I'm going to show you some examples of that. And then we have to think about whether the changes that we're making and the training that we're doing is only to improve the efficiency and the cost effectiveness and the process of care, or is it actually training to make a difference for our patients and families? And so thinking about what we do, and if you think to how we train now, we oftentimes, when something new, a new way to train comes up, we add it on top of all the other training we do. But we forget or we refuse to remove the ineffective training that we are already doing. And so in order to move forward, we're going to have to decide very critically what kind of training do we need to get rid of to open up time for effective training to occur. And we can probably use wearables, technology, linkage, things in our environment that are being used now to monitor and watch us and know our patterns of behavior, our anxiety, facial recognition, etc., that are all over even the streets of Bogota. And how can we use this in the hospital environment to improve our care? Is it going to be possible to sense the pain or the anxiety of a patient or a parent by facial recognition software? How about providers when they're stressed? How are we going to start to use this information in a better way to move forward? And finally, one of the key messages, along with one size doesn't fit all, audit and review and debriefing is a key. So we have mentioned that when we look at large hospital systems, like CHOP with 540 beds and many, many, many providers and patients, that the number of teams that work together on a given day are very large, more than 1 million. So the type of training that we have to do to make this efficient and make excellent care is very important. Because we're not trying, most of our courses, most of our training is to bring beginners up to minimal competence. But for us here in the audience, minimal competence is not good enough. It's not like a driver's license that you have to just get over the bar to be able to drive. We want excellent care. And so we have to train to excellence like the Olympic athletes. And how much training do we need to do? How many people need to be trained? We have to think more like the infectious disease people. They know that perhaps they won't be able to immunize everybody in the community, but they have calculated how many people need to be inoculated to protect that community from the disease and the disease spread. Generally, 93% of the population needs to be inoculated. But we can use this concept of herd immunity in our training as well, because there are different multipliers, there are different numbers of people. Perhaps for advanced resuscitation, only one person per shift needs to be really, truly, expertly trained, if the others are trained as followers and can follow directions and work as a team. So that the knowledge base could even be regulated by a single person or remotely by telemedicine, by an expert with on the shoulder, observing and consulting. So we have to think about different ways of creating this herd immunity. And we know that etiology of the problem will affect our treatment paradigm. How can we better recognize what needs to be done so we can activate those things that work? But think about ourselves in a complex hospital like Cardioinfantil. Think about the different types of problems that we have. And think about how we train to take care of that. We usually use cards like PALS and algorithms. It's kind of like one size fits no one instead of one size fits all. So we have to think about how to take the principles of what's on our cards and algorithms and apply them to the patient that we're taking care of at that time. The principles of prediction, detection, assessment, teamwork, communication, monitoring, and feedback and quality are all the same for every patient. But the disease process and the provider expertise and the team around them changes all the time. So how can we use low-dose, high-frequency training for skills and behaviors for the individual, for the team, and for the environment to improve practice? For CPR training, we started out with a simple cart with a simple mannequin on it. We identified the highest risk patients in our ICU who might have a cardiac arrest, and we rolled the cart around to that patient's bedside, and we asked the nurse and the doctor, the respiratory therapist and the medical student to just show us for 2 minutes good quality CPR on the mannequin. We matched the size of the mannequin to the patient behind the door. And within 2 minutes, they could provide excellent CPR. We looked at the patient's chest, and we saw where the electrodes were attached and where the bandages were, and we simply advised the nurse to create a spot where the pads could go on the chest, so that if the patient had a cardiac arrest, we could rapidly get the treatment that they needed to them. Here's an example of the nurse right outside of the room training on the same equipment that they would use. If you go to a sim center, you might use a different defibrillator or a different size mannequin, etc. But when it's right there in your environment, just in place, just in time, you're using the real equipment and the real providers who are around you. The nurse is identifying her patient what she would do, and the nurse in taking care of the patient on the other side. If I have an emergency, who will cover your patient so you can come in here and help me? So it's not just about that one patient, but about the patients around them that are being cared for, that have to be planned for. We demonstrated that low-dose, high-frequency training could keep us above excellent level instead of the usual drop-off of skills that occurs over 3 to 6 months with CPR training time and time again. This is like a booster shot, or like giving multiple doses of antibiotics to reach a steady state. And once you reach steady state, you maintain a high level. Just the same with CPR education training. We demonstrated using CPR recording mannequins that when we did this rolling refresher program, within 2 minutes, each of the providers, here given the subjects on the y-axis, and the chest compression rate with a target rate of 100 to 120, we could see that when they started, they had a very broad range of chest compression rates. And within 2 minutes, they were able to narrow it down to be within the guidelines. So it didn't take much training. It was refresher training. It was just in time. It was just in place. And when we actually measured the performance before and after, you'll see that we narrowed and improved the compliance with the guidelines, not just on the mannequins outside of the room, but when those children rested, we improved getting with the guidelines on the patients in the room and the survival improved. Here you can see that when we delivered in the gray, the appropriate depth of chest compressions, which we actually measured on real patients in our ICU during cardiac arrest, that all of the survival was better than when we didn't achieve the recommended depth. And more than 4 times children survived when we were with the guidelines. So we did a study where we did all of this bedside training, and then we provided feedback afterwards with debriefings to show them what they had done on the real patients, 18 months before and 18 months after the implementation of this just-in-time, just-in-place training program, coupled with debriefing and audit. And what we found was that for every category of depth, rate, CPR fraction, leaning on the chest, excellent CPR, we improved in the dark columns here, we improved the delivery of excellent quality CPR with the guidelines. That's nice. The process of care improved. We spent a lot of time and effort to do it. But what really mattered was that the survival to discharge and the good neurologic outcome almost doubled. So it wasn't one thing. It wasn't just the skill. It wasn't just the behavior. It was the bundle of training, just in time, just in place, coupled with a concentrated effort across the spectrum of care that seemed to make a difference for survival and good neurologic outcome. In fact, this is not unique to just our unit at CHOP. This has been rolled out now and shown and published in neonatal sites, where brief on-site simulation training, this time in Tanzania. So this is a resource-limited setting where we brought small mannequins, just intubation heads, and the nurse midwives and the providers who attended births, where they were having a high number of still births, no breath, were able to practice, when they started their shift, giving 5 breaths of life to the mannequin and showing that they could demonstrate good quality bag mask ventilation. And then during their shift, if they had a newborn who didn't start breathing, they would be videotaped. We videotaped all the resuscitations and demonstrated that they gave better quality ventilation, and they improved their survival and their 24-hour mortality in a setting where those children otherwise would have died. There are more than 1 million babies across the world each year that die from apnea at birth, who simply with a breath of life could live a full and normal life. So there's a lot of opportunity where this demonstration in a small resource-limited setting could be disseminated with a very simple basic tool that costs very little money. But in a high-resource setting like ours, we know that high-quality CPR is not so common. Better CPR is associated with better outcome. Point-of-care training in our setting improved CPR quality, and that coupled with debrief improved outcomes. And goal-directed CPR can, after the resuscitation, improve survival outcomes. But how do we train that? How do we embed that in the care? We are now embarking on an 8-center study sponsored by the NIH, where we're taking that bundle of care and training that was implemented and successful at a single center, CHOP, and rolling it out across 8 additional centers, before and after in a stepped wedge design, to try to understand whether there are different factors that are impacting outcome, so that we're going to use point-of-care training and post-cardiac arrest debriefing. We're now about 3/4 of the way through the study. We haven't broken the code to know how much of an impact it's making, but it's being implemented at each center sequentially. At the end of the study, all of the centers will have implemented it. And the American Heart Association has now adopted this in what they call the RQI program. They are commercially making rolling refresher carts with recording CPR mannequins. They're training for their basic and advanced life support courses, BLS, PALS, ACLS, are now embedded so that you go online and you virtually test off on the team training and you do your skills and behaviors on the mannequin every 3 months to update your certification continuously. The next generation of this program is intended to capture real events that you report where you're properly debriefed and monitored during real resuscitations. You can load it into the system and substitute it for your mannequin training. And by a learning management system then, you can start to embed your care with your training with your care. At CHOP, how are we trying to move this forward? We have little rooms next to the ICU, next to the different wards, where you can practice simple skills prior to doing them. Lumbar punctures, bag mask ventilation, tracheal intubation, simple basic skills that need muscle memory. Here are some of our fellows practicing skills training and calisthenics. They then are observed by a senior person so that they're not learning things wrong or reinforcing poor behaviors. They then go to the bedside and a single person, here central line insertion being instructed, but the people who are surrounding this person who is gowned and gloved are the other fellows who are also learning how to do it. They're peer coaching. They're learning how to critique and advise without insulting in a manner that they rotate who's doing it and who's commenting. So they learn how to give and receive feedback in a helpful manner during a procedure. And now they're all gowned and gloved and masked up. It's a simulator in the bed. And now they're practicing responding to an emergency during the central line insertion where a hemothorax occurs, and figuring out who's monitoring, who's treating, and how not to get distracted by their concentration on the central line insertion. We then take it to the room right next to the ICU, where we can take a patient who's going to be extubated, tracheal tube removed, and we can reenact or pre-enact that act. We can take all the physiologic principles of that patient, the fact that they're hemodynamically unstable, on vasopressors, but ready to be extubated for other reasons. And we can practice extubating that patient and responding to the hemodynamic response of taking the positive pressure of the ventilator off and transitioning to negative pressure, natural breathing. And in doing that, we can have the team that's going to do the extubation actually practice and anticipate the emergencies they're going to encounter and practice responding to them before it happens. This, Akira Nishisaki, one of our attendings, came into the ICU every morning for 1 whole year to train the team before the residents took their call for a year, and demonstrated that not only was the care improved, but the participation of the residents actually doing the procedures increased, because the team already knew from the simulation that they were competent to do the intubation, to manage the emergency, and to handle the situation. And the supervising attendings had much more reassurance. Their blood pressure was lower, their anxiety was lower, because they knew that this team had already practiced before they performed. We also capture simulations and real resuscitations in our resuscitation bay. Here's an example where we videotaped a trauma simulation in Philadelphia of a gunshot wound of an adolescent. The gunshot wound had gone in one side of the chest and out the back. And the trauma team that was responding during this simulation didn't recognize that the exit wound was bleeding very profusely because they never did a survey where they turned the patient over. This was actually a reenactment because we had a real patient that came in the week before. And because of that, there was a delayed recognition of the bleeding. And so, because of that case, we reenacted this simulation with all of the trauma team members so that we would not forget, and we would enable all of the teams to benefit from the learning that debriefing on that individual case had occurred. We're starting to use different techniques like blindfolding in simulation the team leader to improve the communication of the team members and the team leader. And we're doing follow-up using What's Up. So for instance, in India, when we teach the resuscitation courses, we give them a certificate of course completion at the end of the course, like PALS. But we don't actually give them credit for certification until through What's Up they've shown and kept in contact with their instructor 10 cases of opening the airway, providing effective ventilation, resuscitating shock. And after they've cataloged that they've used the skills that they learned in the course in their clinical setting appropriately, then they get their certificate of certification. I can do these things. So rather than just believing that a course trains us and prepares us, it's actually trying to use the information. But what else does that provide us? Now the instructors of the course figure out what worked and what didn't. What didn't we train well enough? What should we spend more time on in the course training? Because they're having difficulty opening the airway or providing effective bag mask ventilation. We should adjust our training principles. We're starting to gather the information that the course makers need in order to make better courses. I'm going to finish by saying that coaching and training doesn't just happen by the experts, but it's by peers. Betsy Hunt at Johns Hopkins University, in collaboration with the INSPIRE Network, an international network of simulation-based pediatric investigators for research and education, 108 children's hospitals across the world are collaborating to study the effect of a CPR coach embedded into our resuscitation. In simulation, we demonstrated that optimizing performance with a CPR coach, not the team leader, but an additional person to organize the CPR delivery, was very effective in improving the quality of CPR and the surrogate outcomes. And so the question was really asked, if we have no CPR coach or a dedicated trained CPR coach, would the outcome be better? And what they demonstrated in simulation was that for each aspect of excellent CPR, depth, rate, chest compression fraction in the dark bars, when a CPR coach was present, the performance was better. And here the dark bars being smaller is good because these are interruptions in chest compressions, pre-shock, post-shock, and during and around the shock. So the components of process of care were better. And they organized and developed a system so that the eye contact between the team leader, the airway manager, intubator, and the CPR coach were optimized around the bedside and are now in the process of training and studying this and collecting information from real ERs at Cincinnati Children's National Medical Center and CHOP on how the resuscitations are being organized and done. This allows us to learn, to respond, to monitor, and anticipate the problems, and to take a patient care event, replay it in a simulated event, and then monitor the quality of the next patient care event. This cycle of continuous quality improvement, training embedded into care, is important, and is part of our blossoming Center for Pediatric Resuscitation at CHOP. So let's come back and finish with the end in mind. We've discussed that one size doesn't fit all, that high-quality CPR, as an example, can train skills, behaviors, and teamwork, but needs to be embedded in the real environment. Low-dose, high-frequency training is effective and perhaps more effective when combined with knowledge and skills in a course. And just-in-time training allows the teachable moment when I'm most ready to receive that training to have highest impact. The use of live capture, video, and other techniques to capture what's really happening, work as done, not work as imagined, is quite helpful. And the highly practiced teams, like we're learning from sports teams, using sports coaches, can be quite effective, and we're studying its impact now. Using clinical collaboratories to collect data, and not focusing just on process of care, but really on patient outcomes is important. And it's important not just to rely on studies in highly resourced centers, but to see how the implementation of those processes and training practices actually affects care in your hospital and your practice. And thinking about how we can better assess and use human factors, auditing and debriefing. It is a team process, it's a continual process, and it takes a village, and I thank you for your time.